Good afternoon and welcome to today's webinar titled Regenerative Medicine, Proven Treatments, Unproven Treatments, and the Policies that Promote Both. Thank you for joining us online. My name is Kirsten Matthews and I'm the Baker Institute Fellow in Science and Technology Policy at Rice University. I'm also the Director of the Science and Technology Policy Program and the Biomedical Research Program in the Center for Health and Biosciences. Today's event is a collaboration between the Baker Institute Center for Health and Biosciences and the Texas Heart Institute located in the Texas Medical Center. The series was started in 2016 and is funded by a grant by the George and Mary Josephine Hammond Foundation, who have sponsored the entire series that discusses regenerative medicine, stem cells in Texas since we started in 2016. Before we start the discussion, I just would really like to acknowledge one person, one of the inspirations for this lecture series, Dr. James Willerson, who passed away last September. Dr. Willerson was a cardiologist and the former president of Texas Heart Institute and the University of Texas Health Science Center at Houston. He was an amazing doctor and cardiologist, a great science advocate, and an inspiration and mentor to myself as well as many others. He will always hold a special place for me personally because he signed my diploma for my PhD, which is in my office. But without his leadership, the series would not have been possible. And I would like to acknowledge the work that he did. I would also like to thank the Baker Institute staff, especially Cecilia Zook and Daniel Morali, for their support organizing today's event, as well as my collaborator at Texas Heart Institute, Carrie Sprung. Our panelists today are Dr. Emerson Perrin and Zubin Master. Each speaker will give brief remarks, and then we'll open up for a discussion at the end for everybody. So please feel free to submit questions during the presentation or at the end of the presentations in the question box, and we'll try to get to as many as possible at the end. First is Dr. Emerson Perrin. Dr. Perrin is a practicing interventional cardiologist and the medical director at the Texas Heart Institute. He's also the director of THI's Center for Clinical Research and Stem Cell Center. He also holds additional appointments as director of interventional cardiology and medical director of the cardiac catheter laboratories at Baylor St. Luke's Medical Center. Dr. Perrin has led the field in clinical work in regenerative medicine for cardiac treatments. Today, he will discuss his research using stem cell therapies to improve heart function and health and give us some new and promising data from Texas Heart Institute. Dr. Perrin?
Well, thank you for the introduction. And I also want to just remember Jim Willerson as well. He was my mentor, and I'm sure he would be, or is, as he's watching this, he's incredibly delighted with the things that are happening and progressing in this field. He was a very big enthusiast of regenerative medicine. So I also want to thank the Baker Institute for having us and helping us get the word on some of these things. And my first slide is really, this whole regenerative medicine, cell therapy, stem cell therapy, all this has some controversy, definitely some overstatements in the field and some over enthusiasm. And I guess in part, some of that may be due to some of the scientists as we see what the possibilities are in this amazing field. But I just wanted to kind of get back down to earth and think about, science a little bit and the quest of science, which is basically to, look in our natural world and discover, understand. It's really not discovering. The objective truths are what they are. But for us as humans to look around us and understand these objective truths and come to be able to incorporate these things into our lives, which will make our lives more meaningful. They allow for progress and for humanity to be where it's at. And so being human, however, sometimes opposes some of the forces of science. And really, when we try to understand things, the degree to which we believe something is true should be proportional to the amount of evidence that it surrounds that. And sometimes that's easy to find, and sometimes it's hard. So let's just think, for example, the earth is round. I mean, that is a objective truth. In today's world, even, anyway, I just hesitate to mention that, but that is an objective truth. And if you think about that, and you're in the ancient world, and the guys they look at one obelisk and look at the other, they look at the shadow, they can actually calculate the curvature of the earth and what the circumference of the earth is, and they've proven that the earth is round. Again, they've enriched their society by coming up with a very important piece of knowledge. And so these are things that many of which we take for granted in everyday life. What temperature does water boil at sea level, or what's the speed of sound? These are all things that science contributes more than one may think to the progress of everyday life. And in our current state here, sort of at the trail end of this pandemic, is also enabled us to develop a vaccine based upon a lot of research and science that had been done previously, and do this very quickly with some injection of capital. So our part as scientists is to ask questions, and the scientific method really boils down to, you have to do whatever it takes to not fool yourself into thinking that something is true that is not, or if the other way around. And as I had mentioned, as humans, we have a lot of biases. And for example, if you do an internet search, that's the ultimate example of confirmation bias, because you kind of find what you're looking for. We love testimony. When we hear a beautiful story or something convincing, and our human nature is to want to believe a single human testimony, as opposed to looking at a bunch of cold statistics and try to gain knowledge from that. So we really have to strive to understand our world and make progress in science. So with that said, my topic is talk a little bit about the research we've done in stem cells, and the hype surrounding this is just unbelievable. You can see, actually, I was just looking carefully at these little bottles. So the cell IQ, the marketing is just, and then we have caviar in that, because maybe that makes it better. And it's Nachtcreme in German, maybe that's just a little bit better, or French. And, so this is not stem cell therapy, although many of us want to believe it. Maybe we heard from a friend, oh, this is a fantastic cream, and oh my God, and your skin is so smooth if you use this. And so not everything we do is based on scientific truth. Not that everything needs to be based on that, but important things should, especially when we're dealing with our healthcare and our future. And sometimes we get into things that might actually harm us. And so here's an example of that. Beautiful brochure, Celltex, a company that's basically set up to make money off of hope of people, making a lot of false claims about a lot of diseases. And the truth is, and I'll go through the diseases that I'm particularly have some expertise in, and I can show you some of these data points that we do have that we're working towards understanding and trying to get to objective truths regarding how we can treat humans or cure humans even of certain diseases using the power of stem cells. But this certainly is not that, but this is all around us. And so a lot of marketing and a lot of quote unquote testimony about a lot of things sometimes influence people to actually even engage doing dangerous things. So as new things come along, they kind of go through a cycle. This is a Gartner hype cycle, which is a firm on Wall Street that came up with this. And they're experts in evaluating new technologies. But typically new things go through sort of phases of sort of this peak expectations. And they're quite inflated because whatever it is that new, if you think about 3D printing, it's really now sort of coming into its own. But 10, 15 years ago when it first came, yeah, there was a lot of hype, but then people go like, well, maybe this thing is not so great after all because we can't do much with it. And every new thing in its own way kind of goes through these cycles of peaked or inflated expectations. So here's a car, and it has 4 wheels and an engine, and it runs. And so you could say this is a car. This is a car, actually by the same parent company. And it has 4 wheels and an engine, and it runs too. So sometimes we have to be careful when we define things about what is what. And in cell therapy, a cell is not a cell. And that I use this slide to tell you, when you talk about stem cell therapy, you're talking about 1,000 different treatments. Okay, so there is no stem cell therapy. There are different aspects of different things that we can harness and apply to certain situations, some of which we have a little knowledge about that can help people out. So my focus really is on heart disease, and heart failure is the #1 killer of people in the world. People have heart attacks, hearts dilate, they try to adapt to the damage that they sustain, and unfortunately, many people wind up succumbing of either the poor pumping capability of the heart or the consequences such as rhythms and other things that can happen due to that. And the way these cells can work is many-fold. And as we have found over time, and this is part of our journey, is really understanding the mechanisms by which these cells have a positive effect. And now we understand a lot more than we did when we first started out. We actually started out with some quite naive notions that one might think, oh, stem cells, they create tissues, and so we'll put them in there and we'll get a magical solution. And there's no magic. And so over the years, doing experiments, understanding one little thing at a time, we can start putting things together and try to get somewhere. So this is a list of trials that we've performed here and led here from the Texas Heart Institute specifically in heart failure. And you can see on the left column, you'll see different cell types. So you can see over time, we've evaluated different kinds of cells. And each of these is except for the first one, a randomized, double-blinded, placebo-controlled, very rigorously performed trial. The very first one is the first time we ever did it in humans, so that we get a little leeway. We do it in very sick people that don't have much of an option, just to make sure it's safe and a doable kind of thing. But after these first steps, then we move ahead. There are other trials we participated. So there, just to show you, just in this topic regarding stem cells and heart failure, there is a universe of experiments and studies that are all aimed at helping us get a deeper understanding of what we're dealing with so we can apply this to disease. We have been part, and this just ended a couple of years ago now, of 2 iterations of a national cell therapy network, which was sponsored by the National Heart, Lung, and Blood Institute. And this was very helpful because this helped us with many of these studies and putting them into place. So what we do now is really, after many, many trials, is sort of refined our understanding of what we can do, the kind of cells that we can use. And here on the right, that colored ball that's a 3-dimensional map of a heart. The little black dots are where we have injected cells. And actually, this is the ultimate expression of what we like to call precision medicine, which is a kind of a modern thing, because we're actually being very precise about where we're putting those cells. That color coding on the surface, on the internal surface of the heart there in red, for example, represents low voltage. So we're being very precise about how we place these cells and how we deliver them into the heart muscle. So this is the way that we've found that seems to be very efficient and seems to work. And along the way, we've done a lot of things. And so this is an example of studies in animals in which we're putting cells in and we're imaging them over time. You can see here, this is over a period of 6 months. We're looking at how these cells traffic through the heart, and we image them and get a better understanding of what we're dealing with. There are many, many, many questions to be answered. I always tell people, yeah, I'll put that in my queue of things I need to figure out. But so what I want to do just very briefly is show you a couple of mistakes, how the vagaries of science and how it's not really mistakes, but how we learn things. So this first trial is a trial that we did in Brazil. And here you can see the maps on the procedure on the left side. These are two different kinds of maps. The top one's an electrical one, and you can see how the electricity, as represented by those purple colors on the spectrum of visible light, that the voltages, which is proportional to how viable the heart tissue is, really wakes up after you've given stem cells. And this is a very objective thing, and it was very interesting to us in our initial experience. And in that initial experience, we put people on a treadmill and we did this test, and they could perform better. And that's quite a significant improvement that these people had when they got the cells. Well, so that was a very small initial experience. We came to the US and did it with a couple of sites, did the same thing. That's our graph. It's like, whoa, wait a minute. I got nothing. And this is science. This is, if you don't run into things like this all the time, you're probably not doing the right things. So this gives us a moment to think about, oh, okay, well, if that experiment worked one way over there, how come it's not working over here? And then you go into the process of really trying to understand what is underneath the things that you're observing. So in this example, we can see that these different cells, and these are the number of patients in the trial, and the bar graphs represent the growth of colonies. Stem cells, when you plate them, they grow. And so the growth of colonies characterized by the different samples that each of these patients had. And a normal growth would be over in the blue area. So you get a lot of colonies, like 30, 40, 50 colonies. And you can see that in most of the patients, they didn't even grow. Most of them were below a normal level. Well, if you put stem cells that are supposed to grow into people and they're not growing, you're probably not going to get a lot of results out of it. So we went and figured out that, wow, as we're giving these people their own stem cells, the younger people, they have cells that grow more. And so when we slice the population and we look at the younger ones, we see that they indeed have more colony forming cells. And then we look at that same data. Now we see the curve separating. So this is how we learn things. And from this, we go like, okay, this is another trial we did with these similar kinds of cells. Here we didn't see any significant changes, but we were kind of ready to anticipating the results we were going to have. So sometimes not having fantastic, bombastic, positive things is a good thing, because you wind up, you have to pay your dues with everything. So you wind up learning how to do things a step at a time. So this slide here pretty much came from our lesson that we learned with that first trial, is that when you use autologous therapy, you're giving everybody, every individual patient gets a different treatment because they're getting their own cells. And if that patient has a lot of diabetes and is sedentary, and is a smoker, and his stem cells are terrible, he's very old, that medicine that we're giving him is going to be a lot weaker than if we got stem cells from an Olympic athlete that's 18 years old and his cells are ready to rock and roll. So we just found out that there's a lot of variability when you use autologous therapy. So I'll skip over about 10 trials, and we'll go to something that is now that I'm going to end with, which is very exciting. I can't tell you the whole story, but I can tell you, just tease you with just a little bit. So one of the solutions is to use an allogenic cell source. That means not use your own cells, but use the Olympic athlete cells, because stem cells, they self-renew. We can get a sample from somebody. We can grow 1,000 doses from that one Olympic athlete that we harvest a cell from, and treat everybody with the same thing. Now it is kind of like a medicine. So this is a very attractive way of doing it. Only certain cells, though, kind of fly under the radar of immunity. And so this is the case with these cells. So we really have pursued these cells as one of the avenues that we want to use to treat heart failure. And this is a little complicated, but just to say that these cells, in a way, this is the sort of the intelligence of nature, because we're understanding some things, but the cells do a lot. If you put them in the right environment, remember I talked about how precisely we were placing these cells? So if you put them in the midst of inflammation, there are certain things that are happening in that tissue that signal these cells to act a certain way. If you put them in a different kind of tissue, they would act differently. So if you put them in this oxygen-starved heart muscle with these cytokines that are very inflammatory prone, the cells then secrete things to change their environment, to change the inflammation, to even change cells. You see M1 to that green M2, to a polarizing different kind of macrophages to a more healing kind of macrophage, and other substances that are going to act on the muscle, act on the vasculature, even for afar, and act on the linings in the capillaries. So these cells have a great ability to respond to their environment. And as I mentioned that they can do things from afar, here's the ultimate example. So this was a study that was done with these exact same cells in a trial in which LVADs were implanted. And the kinds of LVADs these patients wound up having are continuous flow. So it's a pump that doesn't have a pulse. And one of the things that we know about that is that these patients tend to have bleeding, gastrointestinal bleeding. And that is because there's some substances that you secrete when you have this in place that causes alteration in the little capillaries, especially in the gut. Well, when we gave these cells at the time of putting the LVAD in the heart, later on, there was a 70% reduction in bleeding in the gut. So here we have an endocrine effect, something that we put in the heart, and the effect of these cells to their what they're doing and seeing and putting in the environment has modified a different organ. So this is powerful stuff. This is how we learn things. So we did a phase 2 of heart failure with these particular cells at 6 centers, and it was a dose escalation. So we used a small dose, a medium, and a large dose, and we did this gradually. So you can see the 3 groups. This is the first time we've ever used these kinds of cells in heart failure. So we had to go to the FDA every time. And you can see the dates there between the small and the 75, which is the medium, in May. And then in February, we continued with the large dose, 150 million cells. Each group then was divided in active treatment and control patients. And I'll skip over this, but it is important to know that we did not see any immunological problems with these cells as we expected was the case, but we had to prove that to be able to go forward. So here are some results of this phase 2 trial. And what you can see as we look, so LVESV, sorry for the complicated stuff, but that middle box, that shows left ventricular, with the left ventricle is the pump of the heart. End systolic volume, so that's the volume after when the heart contracts, that's the volume. And then when it fills, that's the end diastolic volume. So if you look at those 2 volumes, you have an idea of how the heart is contracting. So you can see that the heart at 6 months, and we had the different doses. The first column, the light blue, is the control, so that was nothing. The next one is a low dose, the next one's a medium dose, and the last one is a large dose. And you notice in that large dose that the volume went down. Remember when I showed you that slide that shows the heart gets bigger with heart failure? Well, here the heart remodeled and came down. That's what we're looking for, and that's very hard to get. This is the same thing with end diastolic volume. Again, you can see in a dose escalation, proportional to the dose, when we hit that threshold of 150 million cells, those patients had a decrease in an end diastolic volume. This is something we hadn't seen before. And they also, and we do other tests, they improve their ability to walk. We do the 6-minute walk test, so they improve their ability to walk. And more importantly, we looked at the events these people have. So unfortunately, people with heart failure, they go along and they go into the hospital. And that's one thing you can kind of do to evaluate people with heart failure, is see how many recurrent hospitalizations they're having. And unfortunately, many of them die, and you can see how many people die. They have heart attacks along the way that make the heart failure worse. So this is sort of the natural course of heart failure. And this is in this phase 2 study, you can see on the top line that the biggest dose was associated with no events. Okay, nobody died. And it's almost unbelievable. Again, it's a small study. The other 2, the medium and the small dose, tracked along with the control dose. So we think that there's some threshold there that we reached, and those patients, and this is over a 3-year period, didn't have any events. So this led us to say, well, wait a minute, I think we're finally onto something after all these years with this cell in this situation, how we're putting it. So let's get more robust data. And so we designed a phase 3 trial called DREAM-HF that is now finished, and we have a 1-year follow-up. And this is a large study in this terms with 570 patients that was done across 52 sites in the US and Canada, and passed a series of pre-specified analyses, which is very important in this kind of trial. So you have a sense that you're making progress and going in the right direction. So I'm going to show you 2 slides from this because these are part of the press release, and this is what I'll end with. But I'm preparing a manuscript for the New England Journal of Medicine on this, and I just want to tease you with something. And this is kind of similar to what I showed you before in our very beginning experience back in the early 2000s. This is the primary endpoint: recurrent hospitalizations in the 2 groups. This is 537 patients, no difference, okay? But we've learned a lot since then, and we've learned how to look at these events. So this particular thing where people are short of breath and they come into the hospital, the cells did not affect that. But the cells did affect how many people had heart attacks, how many people had strokes, and death as well. That's not on this slide. And I can sort of start showing you that with these cells over a period of, and you can see there the average follow-up is 2,000 days, for a period of 5 years, have a 60% reduction in heart attacks and stroke by giving these patients an injection of these cells up front. So I'll just leave you with that teaser. You will hear more about this, but I just want to tell you that this now is in the realm of, it's not an objective truth. We have so much to find out about this, but this is very objective evidence that really is something we go to the FDA with, and that the FDA can then say, oh, we see evidence of this. Let's let you then maybe turn this into a actual practical treatment. So as you get data over time, we start getting into what we call slope of enlightenment, and these very promising treatments that are just hyped in the beginning. As we have science and data supporting findings, we now get to a point, and that is the point that we're at with stem cell therapy for heart failure, very specifically, in which there is a lot of data and hope that we are very close to an approval of this treatment. And with that, I'll stop, and I understand that the real fun part is more in the discussion. So thank you very much.
Thank you so much, Dr. Perrin. That was an excellent talk. And if you have questions for Dr. Perrin about his research or what he talked about today, or other questions, please leave them in the question box, and we'll actually go through all those questions at the end after our next speaker. So our next speaker is Dr. Zubin Master. He is an associate professor of bioethics in the Biomedical Ethics Research Program in the Center for Regenerative Medicine at Mayo Clinic. Dr. Masters and I actually have a similar career path. He obtained a PhD in cell and molecular biology and then transitioned during his postdoctoral studies into bioethics and science policy. His work now focuses on understanding how patients and physicians interpret and consider scientific evidence when making health decisions, especially in the context of experimental interventions. He's also interested in ethical issues related to authorship, publications, research integrity, and ethics. I know Dr. Masters because both of us are currently serving as Goldstein Science Policy Fellows for ISSCR, or the International Society for Stem Cell Research, where we also serve as ex officio members of the Public Policy Committee. He's actually a fantastic colleague and collaborator, and I'm excited to have him this afternoon. In his talk today, he's going to actually describe a little bit about how stem cells are being used, but outside of that clinical practice, which Dr. Perrin so eloquently described, where these treatments are actually being marketed before they're approved by the FDA, while it's still unknown if they work or if they're safe. So with that, I'm going to transition over to Dr. Masters. Your screen's yours now.
Thank you, Dr. Matthews, for that lovely introduction. So I'm going to echo things from what Dr. Perrin mentioned in regards to sort of the stuff that is not necessarily scientifically proven or insufficiently scientifically proven, but yet is marketed, which he captured in his introduction. So the title of my talk is Recognizing the Unproven Stem Cell Treatment Industry, Perceptions, Features, and Marketing Practices. So I think this is important for anyone who is either a physician or a scientist or an aspiring physician or scientist to understand basically the unproven or unregulated stem cell treatment or stem cell intervention industry. We kind of use these terms interchangeably. And I think it's important because at the end of the day, you're going to get questions from the public or you're going to get questions from patients if you're a clinician. And how you discuss things and how you deal with that, I think, is important. So let's talk about some of these features. Okay, so this is a web-based direct-to-consumer advertised industry. You can see some of the slick websites that I've pasted over there. Now, we call this unproven or unapproved because there's varying degrees of evidence, as Dr. Perrin had talked about several of his cardiovascular trials. In different areas, there's differing levels of evidence, and many of them have not been approved fully by the FDA in terms of being allowed to market to patients. And so this is why, again, we term it the unapproved or unproven intervention industry. This is a global industry, and in the US is thought to be the highest market with, as you can see from that third bullet, this market is growing from 570 clinics to about 1,000 clinics today. So these, and I'll show you some slides around the types of marketing practices. This is heavily marketed to the practice. There's been a lot of hype around this. And in that sense, a lot of people are playing on the hype to basically showcase that, hey, there are stem cell therapies and you can get one. And of course, these are out of pocket. These are costly payments, out-of-pocket costs for patients. And so people have done all kinds of things, talk to their community, talk to their family, mortgage their home, look at crowdfunding sources to pay for these interventions. So just showing some data from others in the US, California, Florida, and Texas are by far the 3 states to known to have the largest number of clinics. You can see the table below has some of the hotspot cities. Now, most of the stem cells that are being marketed are from adipose or bone marrow sources, followed by amniotic sources. And if you look at the graph at the bottom, orthopedic pain and sports medicine, those sort of conditions take the lion's share of this unapproved stem cell market. But you can also see very debilitating diseases that are also have these unproven stem cell therapies for things like diabetes, multiple sclerosis, Alzheimer's disease, spinal cord injury, amongst others. Now, unlike the trials that you've heard, there is no systematic collection of data. And therefore, it is really hard for us to understand when you put in something that's not been scientifically well studied, what kind of harms are the result to patients. But you can just see from some of these headlines that there are case studies and media reports to show brain tumors, vision loss, cancers, different types of infections. And of course, some patients have died from this. So there are many physical harms that have occurred to patients. Now, we undertook a study, and I'm going to kind of gloss through the methods, but I'd be happy to take any specific questions. We wanted to understand who is providing these types of interventions. Who are the providers? So we looked at the 3 largest states known to have the highest number of clinics, and we did a lot of retrospective analysis of various databases to understand the backgrounds of the different types of clinicians that are giving these unproven stem cell treatments in those 3 states. So we found a total of 608 providers. Now, the one major finding we found was that this entire industry seems to be very small, mom and pop stem cell shops. So 40% are solo practices, about 20% have 2 to 3 providers, 14% have only 4 to 5 providers, and only 19% have over 6 different types of providers. Now, when we looked at the different types of qualifications of these providers, we found physicians to be the major representative group. But we also found physician assistants. We found complementary and alternative medicine providers, podiatrists, physical therapists, even dentists. And, you don't have to be necessarily a rocket scientist to figure out that maybe some of these, qualifications don't really match up to giving a stem cell treatment for the various clinical conditions that I've discussed. So we then focused on physicians, okay? So, pretty much this is a dude-run industry. It's a 1 to 11 female to male ratio of physicians that are providing these treatments. And most of them have a medical degree, an MD, as opposed to a DO. Now, again, I can take some of the methods questions a little bit later, but I just wanted to talk about the scope of training. So what we did was we looked at whether a clinic that says they're giving stem cell treatments for X, Y, and Z conditions, whether they had one or more physicians who actually could technically qualify to give that based on their residency and fellowship training, based on their specialization. So overall, we found that around half the businesses had one or more physicians that were actually practicing within their scope of training, which means there's half of them did not. Now, when we focused on orthopedic businesses, so businesses, these clinics are only giving stem cell therapy for, let's say, an orthopedic or a sports medicine type of condition, such as osteoarthritis or something along those lines, we found that the majority, 77%, had one or more physicians that was actually practicing within their scope of training. But when we looked at the businesses, the clinics that were giving, a panacea of different types of stem cell treatments for all sorts of conditions, from ALS to cardiovascular conditions, these non-orthopedic focused businesses, we found that 81% had no physicians that were practicing within their scope of training. So, from this, we basically concluded that most people that are giving these stem cell treatments are not qualified, which beckons the question, what are the right qualifications for a clinician to be giving a stem cell treatment? So let's look at a little bit of the marketing practices. Now, the way these stem cell clinics are able to conduct business is that they're trying to make their interventions, these stem cell treatments, look scientifically legit. And they do this in many ways as outlined in that table. They have a prestigious board of clinical and scientific advisors. They may seek ethics review from a for-profit ethics board. They may patent certain things, or at least claim that they have patented their interventions. They may register their intervention as if it was a legitimate clinical trial on clinicaltrials.gov, but they're not collecting data, they're not reporting the data. This isn't a legit clinical trial. And they may put different types of publications to, again, showcase that there's science behind the types of interventions that they're offering. And by far, the way they sell unproven stem cells is primarily through patient or celebrity testimonials, where a patient is telling another patient their story. And as Dr. Perrin mentioned, stories are very powerful. Let me unpack that a little bit more. So in 2019, we did a study of YouTube videos of patient testimonials. And these are patients talking to the viewer, potentially another patient, about their therapeutic journey with stem cells. We used YouTube. Why? Well, it reaches a lot of people. And because degenerative diseases, impact older population, YouTube is one of their a favorable platform for that population. So we decided to look at narratives on YouTube. Now, we looked at 159 videos of 5 major conditions: ALS, cerebral palsy, multiple sclerosis, Parkinson's, and spinal cord injury. What we found is right off the bat, almost all of them were uploaded by those stem cell clinics giving these unproven interventions. And again, almost all of them was a patient not really with a provider in there talking to another patient. So it was that narrative, that story, that is a very powerful way of conveying health information, as I'll show you. This is just some of the metadata, average of 4 minutes in length, the number of subscribers. And what we found is corroborates with other studies that really no one discusses the risks of an unproven intervention, the high costs, or the fact that, this is experimental and needs ethics and regulatory oversight. So we also analyzed the audio and video, just a couple of little tidbits there. About 58% of these videos actually had a patient, for example, acting out a scene. So if it was a Parkinson patient and their tremors were, more controlled, they may say, I have better control over my tremors. We also saw mild video special effects in almost all of the videos. And again, so if someone said, I have 20% control over my tremors, a little 20% will flash out at you. So this wasn't Star Wars. And we found sort of this mild, peaceful melody music without any words playing in, the majority of the videos. Now, here's another powerful part that we found in these patient narratives. We found that 91% of these videos talked about, the benefits. The patient was telling how they benefited from a stem cell treatment. They also, a lot of patients say, I go to my physician, the physician says there's nothing we can do. We've exhausted everything. And so they feel hopelessness. And so in our analysis, we found that a lot of the patients said, we do have hope. We have a lot of hope from the treatment provider, from the treatment, the provider, or the stem cell clinic in general. Over half of them praised the stem cell provider or the clinic, and I'll unpack that in the next slide. And almost a third of them actually recommended to the viewer that you should go and get this stem cell therapy. Now, here's some of the words where patients described, again, the provider or the clinic or the stem cell intervention, using words like, they were compassionate, they were caring, they embraced us, etc. These are some of the quotes. The second quote from an MS patient says, I thank you and I love you because you're my extended family for making me well again. Thanks. And then some also short phrases as well. So overall, this is, a really powerful way. You can look at data, and of course, patients sometimes do look at data, but a narrative, a story is very powerful in conveying health information, especially over a video-based platform. So, what do specialists, what do physicians really think about this industry? There's actually very little analysis that has been done. So we published a paper that just came out a few months ago in Cytotherapy, where we interviewed 25 specialists in these various different specialties: cardiology, ophthalmology, orthopedics, pulmonology, and neurology. And, we found a range of different types of things, but one thing that was, that stood out and that I want to highlight for all of you is that we asked the question, do you think it's acceptable to give a stem cell treatment today? Now, all of the different specialists only spoke within their profession, in their specific area of specialization. All of them, all except orthopedists, basically said, absolutely not. It is, as you can see, some of the quotes, clearly inappropriate or barely legal to be offering an unproven stem cell therapy. Orthopedists, however, had a slightly different viewpoint because there's growing clinical evidence in several areas of orthopedics that may indicate that, potentially an intervention maybe it's probably safe, but maybe also effective over standard of care. And so they said that under certain circumstances, it may be appropriate to offer an unproven stem cell intervention today. And those are outlined in that last set of points. Patients who have these sort of chronic orthopedic type conditions, they've exhausted all other clinical options. There's reasonable safety data and potential benefit for that patient. Patients are well informed of the risks and the benefits, and that these out-of-pocket costs are not completely outrageous. Under those conditions, orthopedists said maybe on a case-by-case basis, it may be appropriate to give one of these interventions. So more and more what we're seeing in society, and especially in the US, is that patients are becoming health consumers. We see this very much in complementary and alternative medicine, especially for cancer treatment. We're seeing this in the sort of the DIY bio movement, where people are, messing around with, gene editing and other technologies on themselves or on organisms in their garage. And we've also seen this more recently, well, not that recently actually, in the right to try movement as well. Patients here are wanting to basically control their healthcare. And so, what I'm starting to see, at least, and others as well, is this sort of social divide where, patients are saying we want access to stem cell interventions, and we want different options, and we're prepared to pay. And of course, they have a differing view of clinical evidence compared to all of us. Some professionals, but not all, are saying stop marketing these unproven stem cell interventions. They look at patients as potentially vulnerable and potentially can be exploited by these sort of providers because of all of the misinformation that is rampant in this area. And they demand, of course, a very high bar of clinical evidence, pretty much an approved phase 3 demonstrating, of course, safety and decent amount of efficacy in using this. At the end of the day, I think we need to bridge this divide. I don't have an answer like a good bioethicist. I can problematize things, but I may not necessarily have a response. There are ways to do this. Certainly, if we could give patients better options by enrolling them in legitimate clinical trials, that would be great. We can also explore sort of compassionate use or expanded access types of options, which are also, you have regulatory, scientific reasoning, regulatory and ethics oversight. Perhaps these are ways that we can bridge this gap. So my take-home messages are relatively simple. There's a lot of misinformation, a lot of hype and aggressive advertising. Patients, of course, have varying different understandings of what is good evidence compared to a scientist or a clinician. And of course, many of the people that have been offering these types of unproven stem cell interventions may be unqualified. And somehow we need to figure out a way as the scientific community how to best address the sort of unmet needs of these chronic disease patients and get better options for them. And with that, just wanted to thank Dr. Matthews for the invite, some of our funders, and many of my wonderful colleagues whom I've done these great collaborations with. Thank you.
Thanks so much. That was a great presentation, I think, and I hope everybody else learned a lot from it. We're bringing Dr. Perrin back, and we're going to go through some of the questions that we got submitted during the presentation. But first, I want to ask Dr. Master specifically is if you can kind of identify some red flags that you would kind of that maybe everybody can be more of aware of, pay attention to, fast and easy ways to understand what falls under something that would sound legitimate versus something that is more questionable.
So really, there is nothing legit when you're talking about an actual stem cell therapy that should be marketed. There really isn't anything other than using bone marrow transplantation for certain blood related types of cancers. There's a few things for vision and a few things for burn victims, but short from that, most of the stuff is in some phase of clinical trial. So if you're a patient and you're considering a stem cell intervention or a regenerative intervention, there are many things that you should, beware of. And you should ask a ton of different types of questions to whomever you're looking for. I'd recommend that probably go to a major medical center for a lot of these types of things, because that's where a lot of these clinical trials and things are done. But you should definitely ask, is this a clinical trial? Is there a clinical trial number? Is it registered? What are the outcome? Is it a phase 1, phase 2 type of clinical trial? And what stem cell sources? What are you using? And if someone is trying to sell you something, and by the way, most clinical trials you don't pay for, so that would also be a red flag. So if people are reluctant to answer, or if they say something like, oh, we're trying to patent this, I can't really answer that question for you, that should be raising certain red flags. Whereas, in a clinical trial, you're giving consent. They're going to take care of you, not just give you a stem cell treatment and let you go. Those are the kinds of things that I think would make me concerned if I was seeking a regenerative intervention.
So I have some questions. Dr. Perrin, did you want to make a comment?
I'll just add that a second opinion is always your friend. Second opinion, I always encourage people to get second opinions, major medical centers. It is, unfortunately, the patients that are not trained in science. I've looked at some of these brochures, and Dr. Masters was referring to, they do have data on there, but if you go and look that up, it's a joke. It's like one case report of something, or so even if it looks like it's sort of pseudoscientific, I would really raise the red flag for those treatments in areas like Parkinson's, multiple sclerosis, things that are hard. Okay, we manage not to have great treatments for those things at present, and we're working very hard on doing those. The bar is higher, and it's less likely that there's going to be some magical stem cell solution for any of that. Whereas I would say in orthopedics and plastic surgery, the bar is lower. The cells have some applications that are a little bit better known there. And there are some scenarios in which they can be helpful in terms of healing. But there, you're not trying to really cure some, crazy, difficult, unsolvable mystery. You're just trying to, move the healing on a little faster. So the bar is lower of what you're trying to do, and that's more acceptable.
Yeah, one of our viewers actually asked specifically about the status of stem cell treatment for Parkinson's. So it sounds like that's also fitting in one of those. If you're getting a treatment, it's in a clinical trial, most likely. There's none that are approved.
Yes, and unfortunately not. I've seen a lot of crazy things from even doctors. I'm from South America originally, so but from some people in South America, I've seen some crazy claims, and in a court of law, testimony is worth something. In science, it is the lowest form of evidence. We could not prove or understand anything based on testimony. And so the bars are very, very different. So you hear somebody like Dr. Master saying, like, oh, yeah, this was okay. That's basically worthless. And people need to fight their urge to want to believe. And unfortunately, the people that want to believe sometimes are in a bad situation where they got some bad disease and there really isn't some fantastic treatment for it. So they're just grasping for straws and trying to get anything they can. And that puts people in a really bad situation, especially when the guys on the other side are looking to cash in on that. So it's double jeopardy.
We got a couple of questions specifically for Dr. Perrin about his research. So one set was actually focused on the immune responses of the cells. One of them asked specifically about the athlete's stem cells, and the other one about if there's immune rejection for allogeneic MSCs. What have you been seeing in your research?
Yeah, so the there always is an immune reaction to anything, but the short answer is for these mesenchymal cells, they really are not attacked in terms of your own immunity. If you get a cell from somebody else, you put it in a tissue, you don't get this inflammation and attack. Whereas, for example, we put heart muscle cells from somebody else into your heart. If we don't give that person immunosuppression drugs like we give a transplant patient, those cells are just going to be attacked by, just like, the vaccine and the virus, the same thing. Your body recognizes something that's foreign and it goes and destroys it. Whereas MSCs just kind of fly under the radar and they can kind of do their thing. They usually don't stay forever, but they stay for longer periods of time, weeks to months.
So Dr. Master, someone was actually asking about the legal responsibilities of these clinics and providers giving unapproved stem cell therapies. Can they be held responsible for the side effects?
Oh, yes, they are held responsible. The problem is that it's very difficult to go after everybody. If there's over 1,000 clinics, The FDA is a small agency with about 15,000 employees, of which only a small enforcement arm. So they can't go after everybody. They go after the most riskiest sort of stem cell clinics. They have been, they have sought legal injunctions, and they have been successful in one case, and there's another case that's ongoing. Patients have also sued for damages, various types of damages, physical harm, emotional damages, financial ruin, things like that as well. And from my understanding, I don't know if there's been a case. Many of them have been settled, but I think there's a couple of class action lawsuits that have been ongoing. The three women that have been blinded in the Florida clinic did a class action lawsuit, for example. So yes, they are held responsible, and their responsibility is to go through the regulatory process. And the FDA has provided a range of different guidances on how to do that. But again, because they're small in size, they kind of, evade that those requirements.
Mm-hmm. Another question for Dr. Perrin is actually related to, you were discussing using younger cells, younger donors, but what about embryonic stem cells? Those seem like the youngest ones you could possibly use. Why didn't you guys use that? Was that based off of religion, politics, or is there a scientific reason that you guys used a different cell type?
Both, really. Well, first of all, there is a sort of a ethical issue, so it's better not to get into that if you don't have to. So if adult stem cells were like, oh, they're terrible, we can't get anything out of this, and it's just a dead end, well, then we'd have to pursue how we could responsibly use embryonic cells. But the truth is that adult stem cells pack an enormous punch, and we're seeing can do great things. So having the choice, it's easier and better, more accessible and more acceptable in very many different aspects to use adult cells. And then scientifically, embryonic cells, there are issues with embryonic cells. It's hard to get them to stop. So many times you put, fetal cardiomyocytes, other things, they reproduce, and it's really hard to control that kind of thing. What we're seeing now is a great benefit of some of the things we're doing is really, for example, these MSCs, they are a just amazing anti-inflammatory treatment in your body. And it turns out that most of the diseases, the manifestations of a lot of things, as heart failure, is systemic inflammation. And so we're not creating these cells that need to form this and create that and the other. They're having an effect on their environment and modulating inflammation in your body. And apparently that yields great dividends. So that's our focus right now. We're sitting on amazing data that will become known pretty soon, that I think will start changing some of the things that we do in cardiovascular medicine anyway.
Mm-hmm. And I guess to your point where embryonic stem cells don't stop, that's also very similar to another thing called a cancer cell. So I think that might also is really not what you're looking for, is a cell that grows infinitely. You just want it to grow. I'm getting your impression you want it to be healthy, but.
Right. So so embryonic cells have the issue with that. And also IPS cells, which were induced pluripotent cells, where you could take a skin cell and treat it with some chemicals and things and genes and turn it in, put it in a time machine, and it turns into a heart cell. And then you take those and put that into somebody. There's a significant concern of cancer with those cells as well. But it's very attractive, and it could be the way that you could use your own cells to treat yourself, but just in a different way. So these are all things that are going to happen over the years. It's just right now where we're at, we don't quite have the means or the understanding to use these safely.
Well, it looks like we're out of time, but I want to thank both of you for being here today, talking with us in discussion. I want to point out to everybody else in the audience as well that we do these webinars on a regular basis, but we really appreciate Dr. Master and Dr. Perrin for taking time out of their extremely busy schedule to join us today. And if you're interested in more science policy, we're actually going to do another event on Monday at 2 p.m. with Central Time. It's a conversation with renowned scientist and vaccine researcher, Dr. Peter Hotez. He's going to be talking about vaccines, the COVID-19 vaccine, vaccine diplomacy, which are all subjects of his new book called Preventing the Next Pandemic, Vaccine Diplomacy in a Time of Anti-Science. And I believe they put the link in the chat if you're interested in learning more about that. But I'm going to finally just say that I really appreciated all your conversations. Hopefully we got to the majority of the questions from the audience, but thank you both for joining us today.
You're welcome. Thanks for the invite.
Thank you. It was a pleasure.
And with that, thank you so much.